Okay, so I'm Valerie Grignol. I'm a surgical oncologist who specializes in the treatment of sarcoma and desmoid tumors at the James Cancer Center. So today I'm going to discuss the approach to the treatment of desmoid, specifically as it relates to surgery. No, we already had some questions about this, but and then okay. So desmoid tumors are difficult. Oh, it's advancing here, but not there. Okay. There we go. Okay, there we go. So desmoid tumors, I do qualify them as malignant tumors because they're locally aggressive and invasive, but they don't metastasize, so we don't define them as a true cancer. But there are many lesions we deal with that in the cancer world that are in this in-between space. And so I still think of them as a cancer because we offer many for patients. We offer many of the same treatments that a cancer patient, a true cancer invasive with chance of metastasizing gets. And so it's hard to distinguish those two. And it is important that that's our thought process around these, that they are malignancies. As surgeons and our interventional radiologist special, we're all about location, right? Anatomy and location. So the first thing I think about is the anatomic location. And we know from many studies that this does have some impact on the natural history and then the treatment decisions we make. So we generally group them into extremity and chest wall tumors, tumors that are in the head and neck region, the abdominal wall, and then the intra-abdominal, so inside the abdomen, as to how they may behave over time and some of the treatments we might offer. Oops, oh, I am sorry. I don't do well with two different things, apparently. Historically, the treatment of desmoids was surgery. We were the people. The issues with that is it is plagued by the morbidity of the operation, as well as in up to 20% of patients, even with a margin negative resection, they do develop recurrences. Another reason we kind of classify them as cancers or malignancies because they can come back. They can involve critical structures, which leads to life-altering surgeries. And historically, there were a variety of medical therapies which were considered, but they had a pretty wide response rate. And so surgery was kind of the mainstay for many, many years. Radiation therapy has also been utilized. However, there's challenges with long-term morbidity related to those treatments as well. So surgery kind of has been was the mainstay for many, many years. But more recently, this is our current treatment paradigm, which I think many others have discussed today, which is active surveillance, or what's known as watchful waiting. This came about as the review of large sarcoma and desmoid center datasets brought forth this paradigm because it was recognized that in asymptomatic patients, monitoring with imaging, up to 20 to 30% of patients would spontaneously regress. The majority of patients will have stability without progression of symptoms or the tumor, and approximately 30% would require treatment. So then for those patients requiring treatment, the main decision currently is between systemic therapy and surgical resection. There are many adjuncts that have been discussed this morning that are coming on board, but that's kind of the major split in my mind. I guess I'm a surgeon, so maybe that's why. And then while other therapies remain part of this armamentarium, they use a little bit more selectively in specific scenarios as we learn more about them. So given this new paradigm, where does surgery fit in the treatment of desmoid tumors? And so this is the EORTC Desmoid Tumor Working Group's consensus approach algorithm. And so diagnosis via a core needle biopsy is recommended. And then the frontline approach is active surveillance for 1 to 2 years. And then here's really where we're going to focus right now. In the instances of progression, what should our next step be? And as you can see here, that next line under, you could see the anatomic location is important. So we have the abdominal wall, the intra-abdominal, the extremity and chest wall tumors, and head neck. So that's our next decision point, that anatomic location. And so for the majority of those locations where it used to say surgery there, the MTX stands for medical therapy, where that used to say surgery or consideration for surgery, but now it's medical therapy. The abdominal wall tumors, typically more superficial, the morbidity usually is less. That's when we would consider surgery as the next step for progressing tumors based on this algorithm. But certainly we have to look at the imaging and we have to individualize it for the patient. So if we're thinking about these two things, when it comes to surgery, the main things we have to consider is what we call the morbidity of the resection, meaning what tissues or organs need to be removed. And if you don't have those, how is life going to be different? What might be necessary for what's called reconstruction, meaning putting things back together. For instance, in the abdominal wall tumors, that can involve what's called a full thickness abdominal wall resection, meaning not just the soft tissue, but the muscles as well, which when you remove those, that creates a hernia. And how do we fill in that space? In an extremity tumor, coverage of exposed nerves and blood vessels is important. Or in the abdomen, the length of intestine that's involved and the resultant function of that intestine postoperatively is important to consider. On the systemic therapy side, again, I'm not a medical oncologist, but this is kind of the surgeon's broad view of the world. We have to think about side effects. We have to think about response rate, and we have to think about how long should we keep them on that medication in terms of how we're monitoring a response. And so it's not really a pro and con list because you can't put surgery morbidity also on the systemic therapy side. It's just a comparison of what are the issues for each of these things, and then weighing them for the individual patient and the tumor. So this is kind of just a graphic representation of some of the anatomic locations and clinical anatomy. So just a picture of someone's leg here and all the muscles. And so behind all those muscles are these neurovascular bundles, which provide the function. And so arteries can be resected and reconstructed in the majority of cases. Veins don't do as well with reconstruction, and they can clot off, which leads to long-standing swelling of that extremity. If the blood doesn't find another route to go, it can require you being on long-standing blood thinners. And then in regards to nerves, the question always is what muscles does that nerve provide function for? And is there an alternative route? Can we reconstruct that nerve and still provide function? Or is there some other thing we can put in place? And if we can't, how do we preserve it safely? The next picture there is a picture of an abdominal wall with a hernia. So what I meant by that hernia is this the? Okay. So what I meant by the hernia is these are the layers of the abdominal wall here. And then if we take out a portion of that muscle, your intestines are going to want to poke through there. That's what a hernia is. And so when we remove that section of abdominal wall, we typically work with the plastic surgeons to either put some what's called mesh in there, a synthetic or bioprosthetic material to close that over, and then try to move some of the remaining muscles over it. But your abdominal wall will not function like it had previously. So you will lose some core strength, which is, important to all of us. And can lead to some long-standing issues if we don't think about that in advance. So you might think, we'll just remove this muscle, everything's going to be fine. But it does have long-term impact on the function of that. And then probably the most critical area where we deal with tumors, which often are unfortunately unresectable, is inside the abdomen, because these tumors like to lay along the mesentery here and those blood vessels. And those blood vessels provide all the blood supply to the intestines. So if the tumor is located very what we call proximal, meaning at the main trunk of those vessels, and trying to remove the tumor, we would damage those vessels, you would lose all your intestinal function, which is really not a great way to live life. And so, those were some of the most challenging tumors for us as surgeons, until we had more effective medical therapies on the market that can impact them. So I think next I just have an example of a use of systemic therapy to aid in surgical resection. So while systemic therapies are important in desmoid tumors, and for some patients, that's all the treatment they will need, for some, it's important for the surgeon to stay involved, because at the point of a nadir of what's called a nadir of response, where nothing's really changing on the scan, we might want to consider whether surgical resection is feasible to render you no evidence of disease or to improve on symptoms related to the tumor. I would say the majority of patients currently don't end up needing surgery, which is great when someone doesn't need my services. However, it's still something we probably should be thinking about. This is an example of a patient who had a very large desmoid tumor of the intestines, of the mesentery of the intestines. It shrank very nicely over time with medical therapies, chemotherapy, and then we were able to go to surgery and remove a much smaller length of intestine, such that it didn't impact their overall digestion and things like that. So that's where this can be kind of a consideration of a combination approach. This is an example of a patient who had very rare situation, but multifocal desmoid of a lower leg. All these little white spaces are where the tumor is. Some of those are blood vessels, but the larger white things are the tumors on the MRI scan. And she'd already had multiple surgeries to try to manage the disease with recurrence. And so now you see it's kind of all those white things have disappeared. This is probably the space where one tumor is. That's the enhancement we talked about. It's no longer enhancing. And after, I think, about 2 years on therapy, we stopped and just watched, and these have never come back. And she didn't need yet another surgery and skin grafts and, scarring to manage the tumor. So this is where systemic therapy can obviate the need for a surgical resection. So I think someone asked this question earlier. When should we operate, right? That's my main question. I think the superficial abdominal wall tumors that are growing and progressive, that's probably the most likely scenario where we're going to consider surgical resection as the next step. But again, even with these superficial tumors for which there would be minimal morbidity, meaning the most you would have is a scar over where the tumor was present, we still have to think about critical structure involvement. The need for a complicated reconstruction also folds into what are the patient's other things that are going on, for instance, like diabetes, which does impact wound healing. And then in my mind, there's always, just like many other cancers, there's consideration for systemic therapy as a first approach to understand the biology of that tumor. How rapidly is it growing? How is it responsive? If this were to ever come back after a surgical resection, do we know what medications would work for it? So, just in summary, from the surgical standpoint, watchful waiting does remain first line, such that many patients previously treated with surgery, it will not be necessary. For symptomatic progressive desmoid, surgical resection and systemic therapy are probably our main treatment strategies at this time. We surgical resection must take into account the morbidity, need for reconstruction, and long-term function. And we need to balance the systemic therapy side effects with response rates. Systemic therapy may be able to increase the number of patients able to undergo resection as a part of a multidisciplinary treatment or obviate the need for surgery. So I think there are still some questions to answer, which I think some of you asked earlier. What's the duration of therapy for a patient who's responding? Like how long, if you're continuing to respond, how long, or if we've reached that nadir, just reviewing it with imaging. What is the order of events? And then should we be operating after a successful response to systemic therapy? So I think these are still the questions, some of the questions for us to answer as surgeons in desmoid treatment. So thank you, and I'll take any questions later.